Okay, let's get started with the concepts of inflammation and infection in Module 6. Okay, let's talk about inflammation first. Inflammation is a normal response. Inflammation is an adaptive response to injury or illness that brings plasma, dissolved substances, blood cells to interstitial tissues where invasion or damage has occurred. Inflammation is nonspecific, and these events occur in the body regardless of the cause. The 5 signs of inflammation are pain, swelling, redness, warmth at the site, and impaired function. And the suffix itis equals inflammation or an indicator of inflammatory process. Keep in mind that these 5 signs may also be an indicator of infection, but these start during the inflammatory process. Okay, the injurious agents can be physical, they can be chemical, and they can also be microorganisms. The inflammatory process is a complex response of vascular tissues triggered by harmful stimuli. So an insult or injury to the tissues causes the onset of the inflammatory process. The inflammatory process can be acute or it can be chronic. Acute inflammation happens within minutes or hours of the insult. Typical signs of inflammation occur. So we talked about the warmth, the redness, the swelling. The inflammatory process continues until the trauma is neutralized. And if the trauma is not neutralized, the response may become chronic. Now, keep in mind, so we're talking about inflammation, not infection. So this is where I said inflammation is always part of infection, but that doesn't mean that infection is always part of inflammation. Chronic inflammation results when the trauma is not neutralized. So chronic inflammation ranges from seasonal allergic reactions to responses in autoimmune disease that damage healthy tissues. Okay, let's talk about the stages of inflammation. Stage 1 occurs when there are vascular and cellular responses. So blood cells at the site constrict temporarily. The injured tissue releases histamines, kinins, and prostaglandins. Here, the blood vessels begin to dilate, causing hyperemia. So there's an influx of blood flow, right, to that area. Vascular permeability increases. So fluid, proteins, and leukocytes leak into the interstitial spaces, causing edema and pain. So the fluid, proteins, and leukocytes are typically in the vascular space, in the veins, right? And now, because of the vascular permeability, those things begin to leak outside, and that's what causes the edema and the pain. Pain is sometimes associated with the edema if the tissues become too engorged with fluid. That can be the cause of the pain. The leukocytes then cause margination and emigration, and then leukocytosis begins to take place. So there's a proliferation of the gathering of white blood cells at that site, right? Stage 2 of the inflammation process is exudate production. So the fluid that escaped from the blood vessels, as we talked about in stage 1, so that fluid, the dead phagocytic and tissue cells form also a fluid. They mix and form a fluid that's either serous. So serous fluid is a thin, watery, clear, or sometimes pale yellow. A purulent, which is pus-like, or hemorrhagic. So typically not bleeding, frank bleeding, but blood tinged. That's the kind of stuff now that forms the exudate in that injured area. And then keep in mind that the exudate that appears over a large surface or with other symptoms indicates a greater degree of medical care that will be required. All right, stage 3 is the repair stage. So cells are going to regenerate, okay? New cells are going to be identical or similar to those that were injured, and the architectural pattern and the function of that tissue will be restored by the regeneration of those same types of cells. There could be replacement, so granulation tissue, as we talked in wound healing, and then also cicatrix or scar tissue could be the replacement tissue type. Okay, so let's talk about independent interventions. Independent meaning nursing. Inflammation that's due to injury, okay? We can reduce the movement of the involved area. So that would be just to keep it still, immobilize it perhaps to reduce the amount of irritation. We could also elevate it to reduce edema, which typically involves the elevation of an extremity. And we can also administer antipyretics or anti-inflammatory medications, of course, depending on the physician order. And then more specific treatment could include antibiotics and or steroids. Of course, that's physician mediated. Preparations for surgery, perhaps if the injury is requiring further care, and also promoting adequate nutrition for healing. Okay, so let's continue on with interventions and therapies. Patient education is always appropriate. So we can educate patients on preventing further injury, so that could mean immobilization of the affected area. It just depends on what the specific injury is. Taking the medications as they're prescribed, whether it's something for fever, whether it's something for to reduce inflammation, whether it's steroids, whether it's antibiotics. Taking medications as prescribed is always an important education piece. Maintaining the intake of liquids and nutrients for proper healing. And then we also may have to include the family depending on how extensive the injury is. So family teaching might include the changing of dressings, bathing, or other activities of daily living, or ADLs. Might also educate the patient and the family about ways to alleviate discomfort and also ways to promote coping. So if the inflammatory process is long-term, and it might include things, as I spoke about in a previous slide, autoimmune disorders, this may involve a significant amount of coping skills because it's going to be long-term, chronic, and typically painful. Okay, pharmacologic therapy, which of course would be administered under a physician's order, nurse practitioner, or physician assistant. The goals in pharmacologic therapy are going to be reduce inflammatory response and reduce associated pain with the response. Common medications for this is going to be NSAIDs to reduce inflammation. Corticosteroids might be used in more life-threatening or severe inflammation, and must be managed carefully. So this isn't something, steroids have to be tapered, and again, we have to be very mindful that we're administering them the way the physician has ordered, and especially that the patient is taking them the way they were prescribed if the patient's going to be taking them at home. Okay, let's talk about lifespan considerations. So children and adolescents have differences in anatomy and physiology that can influence the effects of inflammation in comparison with adults. So children and adolescents have structural differences in the airway, which can be important in the case of an anaphylactic reaction, right? Their lung alveoli are fewer and smaller. The glomerular filtration is not fully developed, so they have a decreased capacity. We talked about this before in elimination, decreased capacity to filter medications. And the absolute volume of fluid loss represents a larger proportion of total body fluid in children and adolescents because their bodies are smaller, right, in comparison with those of adults. So keep in mind that fluid loss to children and adolescents and infants also is going to be more significant. A smaller amount would be more significant loss than found in an adult. Okay, continuing on with children and adolescents, the changes in the development of the heart, it reduces the sympathetic nervous system response to changes in blood volume and stress. So these children, they have an ability to compensate with changes in, for example, blood volume, and also changes in heart rate in comparison with adults, but their ability to sustain the compensation will not be as robust as that of adults. Gastrointestinal inflammation occurs with some injuries. Immune response to insult differs significantly for children and adolescents, and the inflammatory disorders found in children are often related to internal organs. We need to be very careful in interpreting negative blood laboratory results Children with inflammatory disorders may have normal test results. Again, this is just something to be mindful of. We are not going to be interpreting those. We are not going to be announcing this to the family, to the parents, to the patient. Just be mindful of these types of things. The differences in children and adolescents versus adults. If the visualization of an internal organ is necessary, ultrasound is usually used instead of endoscopy. At least in some cases, it's not as invasive, not painful, it's less scary. And then inflammation in children and adolescents is sometimes can be associated with other illness. Okay, so in older adults, let's look at the other end of the spectrum. Inflammatory markers may be increased, which is an indicator of poor overall health. Older adults tend to be more susceptible to chronic illnesses and cognitive decline. Cognitive decline has been associated with the presence of inflammation. Okay, so we've talked about inflammation. Let's talk about the presentation of infection. Infection is defined as the invasion of body tissue by microorganisms with the potential to cause illness or disease. The immune system is the body's major defense. Nurses must think about infection prevention at all times. So just because a patient doesn't present with an active infection doesn't mean that we don't need to be mindful of preventing the onset of infection. Nurses are directly involved in providing a biologically safe environment, and we'll talk a little bit more about that. Microorganisms exist everywhere. Most are harmless, and some are even beneficial. Some are found in normal flora in one part of the body, but may produce infection in another part of the body. So one example of that is E. coli in the gastrointestinal tract. So it plays a role in maintaining the balance between good bacteria and bad bacteria. But E. coli found in another area of the body, for example, in a urinary tract or in a wound, may produce infection in that area. Infection can be asymptomatic, so there are maybe no symptoms of infection, or subclinical infection, which means there's no clinical evidence of disease. A disease state is when microorganisms produce detectable alteration in normal tissue function. Okay, a communicable disease. Communicable diseases are transmitted from one individual or animal to another. One transmission is directly by body fluids, or another transmission is indirectly by becoming in contact with contaminated objects, airborne particles, or vectors. Infectious disease is a major cause of disease and death, and even some subclinical infections can cause damage, so we don't really know it's there. We don't have any reason to believe that there is an infection, but it could be damaging tissues and cells. Okay, let's talk about a pathogen. Pathogen is defined as a microorganism that causes disease, and an opportunistic pathogen causes disease only in susceptible individuals. So what may cause a disease or an infection in me may not cause the same disease or infection in another individual. We're talking this week in lab about aseptic technique. There is medical asepsis, which is the effort to maintain as much cleanliness as possible. Okay, that's medical asepsis. And then there's surgical asepsis, which is known as sterile technique. And then sepsis, we talked about a little bit in class today, is the whole body inflammatory process. So the whole body is inflamed, and the inflammatory process has gone to work to hopefully prevent infection in that individual. There are 4 categories of microorganisms: bacteria, which are the most common cause of infection; viruses, and these are specific to the fact that nucleic acid from the virus must enter a living cell to reproduce. Okay. There's fungi, which include yeasts and molds, and then there's parasites, which include protozoa, helminths, and arthropods. So let's talk about some types of infections. You'll hear the word colonization used often, and frequently this is used in reference to MRSA. So colonization is when microorganisms grow and multiply, but they do not cause disease. So typically we characterize this as an individual has been exposed to that microorganism, but it is not causing an active disease in that individual. So we find MRSA colonization often in the nares of patients, but they're not ill. So we know that they've been exposed because we can identify it, but it's not actively causing an illness. The second phase would be infection, when microorganisms invade part of a body with ineffective defenses. So a microorganism has gone to a specific body part that is not adequately protected, okay, by its normal function. Types of infections can be local or systemic, acute or chronic. Okay, let's look at the chain of infection. There are 6 links in the chain of infection. The first is that there's an etiological agent. So that agent is going to be the bacteria, the virus, the fungus, or the parasite. Okay, that's going to be the infective agent. The second link is the reservoir. So this is the area of entry into the individual. So it's going to be a wound or the urinary tract or the respiratory tract, okay? Then the third link is going to be a portal of exit. So the portal of exit is the way that the microorganism leaves that infected individual and is carried away from the individual onto another either individual or surface that would be the area for another potential infection. So the portal of exit, so the area that where the infection leaves the body and travels somewhere else. The fourth link is the method of transmission. So there's direct, which is if we touch another individual. So I have an infection on a wound in my hand, and then I touch an individual. That would be direct transmission. We also have indirect transmission, which includes vehicle-borne and vector-borne. So vehicle-borne transmission occurs when a substance, so water, soil, some agent of movement, a vehicle, takes an infectious agent to another host, okay, to another individual, to another surface. Vector transmission occurs when an individual carries an infection on its body or as an infective host, like as in colonization, to another individual. So vector-borne is going to be the movement from the infected individual or area surface to another area. And vehicle is going to be movement through a different source, not the actual infected individual. And then we have airborne, which covers airborne diseases, tuberculosis, varicella, shingles, things like that. Okay, so the portal of entry is the actual location of how the microorganism gets into the individual. So I should have been more specific with the reservoir. The reservoir is actually a place where the infection can live. So the parasite, the fungus, the bacteria, or the virus can live. That would be a reservoir. The portal of entry is the actual location where it enters. Okay, so keep in mind that the body has barriers to prevent illness. Skin is a barrier to infectious agents, right? And break in the skin, as I mentioned, maybe I have an infection on a wound on my hand. That serves as a portal of entry, okay, the wound, because it's a break in the skin. Other portals include mouth, throat, nose, eyes, and genitalia. And the reason is that they're open to outside exposure. So obviously our mouth, our throat because we're breathing things in. The nose has mucosa open to the air, eyes the same way, and genitalia. And these are the most frequent portals of entry. And then the last link is a susceptible host. So we have all these things in place, but now we need a host who is at risk for infection. Okay, a susceptible host is someone who is at risk. Those commonly are infants and young children, right? Their immune systems are not as robust and responsive. And then we also have a compromised host. This is an individual more at risk than others for acquiring infection. Okay, let's do a brief physiology review. Okay, there are specific defenses set up by the body, and those include anatomic and physiologic barriers such as intact skin and intact mucous membranes. Okay, the skin serves as a protective barrier to all the tissues inside. Also, the nasal passages. Okay, they have the hair on the inside of the nasal passages that prevent microorganisms from easily passing through. Okay, we have the lungs that have mucus producing cells that help to cleanse the lungs and the respiratory tract and get microorganisms that may be irritants or cause inflammation out, right, by coughing, and we cough out secretions and things like that. And then just keep in mind that every body orifice has protective mechanisms, okay? So every place that there's an opening, the body has been designed to protect itself. Unless that barrier has been broken or impaired in some way, then prevention of disease and illness is working the way it should. Okay, we're going to review the stages of the infectious process, but I'm not going to go very deeply into it. There are 4 stages of the infectious process: the incubation period, the prodromal stage, the illness stage, and then the convalescent stage. And we've all heard about this. The incubation period is the time from exposure to the microorganism to the onset of symptoms, right? And then the prodromal stage continues from is the period of time when the body attempts to, the inflammatory process begins, but then still the body isn't able to completely combat the infectious agent. So we begin the illness stage. Okay, so symptoms are present, and then the convalescent stage where the symptoms are declining and the individual is returning to normal state. We have a carrier state in which the host defenses eliminate infectious disease, and that means that, again, the host may have been exposed to a microorganism. The microorganism continues to multiply, but does not cause disease. Okay, alterations and manifestations. So we're going to talk about healthcare-associated infections. This is a big deal, and it can be a huge problem for a number of reasons. First and foremost is it causes an individual, so one of our patients, contract an illness in the hospital that they didn't come to the hospital already having. So this is a problem because it's not good for them. And then Medicare and Medicaid has also decided that there are certain healthcare associated infections that the facility will not be reimbursed for because it occurred under the care of medical professionals. So healthcare associated infections, or HAIs, can develop during a patient's stay in the facility. The Joint Commission has identified them as never events. So these are preventable with the appropriate nursing and medical care, and should, per the Joint Commission, never happen. Respiratory complications have become a common type of healthcare acquired or associated infection. For example, well, it's going to mention pneumonia in a minute. The top 3 types are the urinary tract infection, which is the most common HAI, a surgical site infection, and also pneumonia. So we can talk about really the most important things about healthcare associated infections, which is the fact that they're preventable. Okay, so hands are a common vehicle for spread. We already know that. We touch one contaminated surface, and then we don't use proper hand washing, and we take that contamination to another surface or another individual, another person. So that's why we say that they're preventable, because one of the most effective ways to prevent infection and the spread of infection are to wash the hands, soap and water. Soap and water may be inadequate to remove the pathogens, and in that case we may move forward to alcohol-based antiseptic hand rubs before and after patient contact. And even with bathing patients, we have gone to the use of chlorhexidine soap in patients who have central lines, dialysis catheters, indwelling urinary catheters, to continue to decrease the amount of microorganisms on the skin surface. Hand hygiene may damage the skin. We see that with frequent hand washing, water that's too warm, dryness on the skin, and also overuse of the alcohol-based foams and antiseptic rubs. So a nurse who develops dermatitis places their patient at higher risk for infection because the nurse has an impaired skin integrity, and without proper healing of that integrity and the proper use of gloves while the skin is impaired, places their patients at a higher risk for contracting microorganisms from them. Okay, so PRSP is penicillin-resistant streptococcus. We have VRE, which is vancomycin-resistant enterococcus. We have VISA and VRSA, which are vancomycin-resistant staphylococcus and vancomycin intermittent staphylococcus, Staph aureus. ESBL producing enterobacteriosi. So ESBL are the extended spectrum beta-lactamase, the carbapenem resistant enterobacteriosi, and then also the multi-drug resistant Pseudomonas aeruginosa. So we're seeing more and more. There's a lot of stuff out there. It used to be way back in the day where MRSA was like a big deal. Like if you had a patient with MRSA, like it was bad news. And now MRSA is pretty much, I mean, it's just kind of a given. I don't know the statistics, but MRSA is just something kind of an everyday thing now. Okay, let's talk real quick about prevalence of contraction of communicable diseases. So the chance of a healthcare worker becoming infected from exposure varies widely from pathogen to pathogen. So the chance of a healthcare worker contracting hepatitis B is about 30%. Hepatitis C is about 1.8%. And then HIV is about 0.3%. So obviously the prevalence varies widely. The Occupational Safety and Health Administration, so OSHA, requires that healthcare employers make available a hepatitis B vaccine. Most hospitals require that the employees have hepatitis B vaccine, and you can see why, right? 30% chance of contracting it. And that varies from facility to facility, but if you're hearing that you're required to receive certain vaccines for as a condition of employment, don't be surprised. And then also the biggest predictor is going to be PPE. Use PPE the way it's prescribed for specific conditions. Okay, genetic considerations and risk factors. There are some things that predispose people to infection. So let's talk about some medical therapies that may have an impact. Radiation treatments, diagnostic procedures, medications, and then any disease that lowers the body's defenses, so diabetes mellitus, and then there are many different chronic diseases we find in older adults predisposing them to infection. Ways that we can promote staying infection-free, and this includes education for patients, is going to be the appropriate hygiene, okay, and that includes, we talked about oral care, we have talked about that. Also proper perineal hygiene, especially in women. Nutrition, fluid status, sleep, stress reduction, and being properly immunized. And all of this can fall under the responsibility of the nurse in patient education. Okay, so good hand hygiene, and this includes educating patients too. Okay, washing hands before and after using the bathroom, before and after eating, getting immunized appropriately. Different life stages require different immunization, so be sure that whatever the physician has recommended, that you're able to educate patients on the benefits of that. Preventing airborne droplets from spreading. So that includes things like coughing or sneezing into your elbow, or coughing or sneezing, down into your shirt. Prevent those droplets from being expelled out into the air. And then also taking precautions when handling potentially contaminated materials. So for healthcare workers, this requires the use of gloves when appropriate, right? Things that are contaminated, so dressings, bed linens, gowns, patient gowns, garbage, measuring Foley catheters, so blood and body fluids. And then also if we have family members who are potentially taking care of the patients, maybe when they go home, so that things would be, those would apply to them as well. So be careful in handling, linens and the blood and body fluids, things like that. We certainly can educate our patients and our families on that kind of stuff. Okay, disinfecting and sterilizing, what is the difference? So both disinfection and sterilization are decontamination processes. Disinfection involves eliminating or decreasing the number of harmful organisms, while sterilization kills all microorganisms. So disinfection is a process that we can do on the nursing unit. Housekeeping would carry out those types of tasks. You may do it as well by the use of sanitizing wipes, by the use of alcohol if that's what's prescribed for especially COVID type settings, bleach wipes in the case of C. difficile. And then we wouldn't, though, on the unit be able to sterilize. That's typically the use of irradiation or heat. So that's not something that's carried out on the nursing unit. If you need a sterile, sterile equipment of some type, so if it's gloves, if it's instruments, those things have to be gotten from Central Sterile Supply, or sterile gloves appropriately packaged without a break in the package that ensures their sterility. Okay. Isolation precautions. I know that you've seen this in the clinical setting. You will continue to see this in the clinical setting. Isolation are measures that are taken with a specific patient, an individual, to prevent the spread of infection. Okay, there are category-specific isolation precautions. There are disease-specific isolation precautions. Okay, the difference is that we sometimes see patients, for example, they're coughing or they're sneezing a lot, so they have, it seems, a respiratory type illness or potential for respiratory illness. So that would be category specific. So we might use a mask while working around them. We might use a face shield to avoid the droplets in our face. We might put a mask on the patient. Okay, that's category specific. Disease specific, though, are isolation precautions that have been assigned after a diagnosis has been made. So, for example, a patient with MRSA, that patient is going to be placed on contact precautions because we already know what the patient's being treated for, and we know the isolation precautions that we need to be in place to protect ourselves. Universal precautions is when we use gloves, and in the case of all patients, we regardless of their diagnosis, regardless of the reason that they're in the hospital, regardless of what we know about their medical condition or their history, universal precautions. So universal precautions means that we wear gloves with every encounter, that we're using hand washing before and after we are caring for the patient, and that anything spills are wiped up immediately. So blood and body fluids, those are cleaned up immediately. It's just a universal. So we sometimes tend to think of, for example, this is a very easy example, patients who have an HIV positive status, there is no special precaution for care of the patient with HIV, because we should be using the same precaution with their blood or body fluids as we use with every other patient. So that's why we call it universal. And that would cover that particular patient unless we know that they do have an infection of another type that needs to be covered under disease specific. So your infection prevention department in the facility where you work can provide information about that, especially the very difficult to assign ones. Sometimes we just don't know what needs to be appropriately assigned to that patient condition. But infection prevention department or also the resource nurse is a good, if they have some experience in nursing, they may be able to help you out there. There's also body substance isolation. So this would be things like patients who have chemotherapeutic agents. So their urine is going to have chemotherapeutic agents in it. Same thing with, for example, patients who have had radioactive seeds placed for the treatment of prostate cancer. Their urine would also be, it's radioactive. So there are specific instances, and those are, depending on where you work, not frequent, but if you have a doubt, please use the appropriate resource to protect yourself and others. This is a link to donning and doffing personal protective equipment. There was also a link in to videos in a previous module, so please review that if you feel the need. So some other precautions are just to avoid injury from sharp instruments. Obviously, we would want to do that. Needle sticks. You need to be very careful with sharp instruments, especially if someone else has used a sharp instrument and you're not entirely sure if it's been disposed of properly. So that would be like a scalpel potentially needs to go in the sharps box in the room, needles. Take measures in cases of exposure to bloodborne pathogens. So if there's an eye splash or there's a body fluid or blood that's gotten into your mouth, unfortunately, or things like a needle stick with a contaminated needle. So there are procedures in place that allow the employee to be properly cared for in those instances. Communicate to employees about biohazards. So there are those types of things for chemotherapeutic agents, for radiation, and also about different chemicals in use in the facility. Federal regulations require warning labels on chemicals that are used for cleaning or whatever the chemical happens to be. Make sure that you know what the MSDS is, medical data safety sheets, and it talks about the hazards of specific chemicals and then how to treat exposure to those chemicals. These are the isolation precautions from the CDC. So here's a link if you want to take a look at those. Okay, so let's go to the nursing process. First step is assessment. Assessing patients for infection is important to treating the patient appropriately and preventing the spread of infection. It's especially important for patients at risk of infection, such as those with IV lines, which is all of our patients, indwelling catheters, and also surgical wounds. Okay, so let's talk about the patient's degree of risk, and be mindful that patients who are in the hospital are there for a reason. They have some dysfunction of a body system or have an active disease process, or so all of these patients, all patients are at risk for infection. Okay, we need to make observations of the patient's current condition. Okay, we need to take a look at their existing disease process. Why are they here in the hospital? History of recurrent infections. Is this, are they having a problem that they've had in the past, or do they have a history of having the same recurrent types of infections? Take a look at their current medications and therapeutic measures. There are medications who can place a patient at higher risk for infection, steroids being one of them. Current emotional stressors. We know that patients who are stressed, which is all patients, people who are stressed have a lower ability to combat illness. Nutritional status. This may be impaired and require that the patient have additional support in that way to promote healing. And then also history of immunizations. Are they at risk for a specific illness because they have not been immunized with the suggested immunizations? Okay, so physical examination, this is continuing of assessment, right? Patient's vital signs. Infection could be indicated by an elevation in temperature, elevation in heart rate. Those would be it could be hypotension. Ear assessment, do they have ear pain? Do they have anything draining from the ear? Oral cavity assessment. Eye assessment, lymph node assessment. That's usually in a little bit of a advanced assessment, but it is important, especially if a patient points it out to you. Lymph nodes are swollen lymph nodes can indicate the presence of infection. Respiratory assessment, so listen to those lungs. Skin assessment, do we see any areas of the skin that are broken or impaired that could be a portal of entry? And then urinary assessment. Urinary tract infection is, we already talked about, one of the most common healthcare associated infections, but our patients coming in with them, we don't want the responsibility to be put on us as a facility if the patient came to us with an urinary tract infection. So are they having pain on urination? Are they having difficulty urinating? Are they having frequent urination in very small amounts? So this is an assessment that can be completed on admission that might tell us that there's already something going on, that the patient did not in fact have or did not get the infection while they were being treated at the facility. Okay, diagnostic test. I don't want you to focus on this specifically, but just be mindful that there are some tools out there that we use to indicate or to detect infection. White blood cell count with or without differential, cultures of a wound, cultures of blood or other infected body fluids, antibiotic peak and trough levels, erythrocyte sedimentation rate. Right now you don't need to know the normals. And then C-reactive protein, which is also something that gives us an indicator of inflammatory response. Again, be mindful that these things are there. Do not, I repeat, do not memorize this slide for the purposes of information in NUR 111. Okay, some additional diagnostic tests. Again, just be mindful that they're out there. These are some things that you could potentially anticipate the provider ordering. Radiologic examination of chest, abdomen, or urinary system. Lumbar puncture. Ultrasonic examination, perhaps an echocardiogram or a renal ultrasound. Urinalysis or stool culture. Okay, so let's talk about independent interventions. This slide is not actually independent interventions because it would be done in collaboration with another specialty or discipline. So the goals of care and treatment of infection are going to be identifying the organ system involved, identifying the causative agent. Okay, the only way we're going to know how to appropriately treat something is to identify what we're treating, and to achieve a cure by the least toxic, least inexpensive, least expensive, actually should be that wording, and the most effective means. So we talked about this. Let's not take in the big guns, okay, for a paper cut as far as antibiotics are concerned, okay? We want the least toxic. We already know that either the liver or the kidneys are going to metabolize the medications that we put in the patient's body. So let's pick the least toxic measure, okay? The least expensive, okay? That only makes just like good sense, right? And the most effective. So maybe the most effective is not the least expensive, okay? And maybe the most effective is not the least toxic. So in that case, that's a provider's discretion. Got to get the most benefit with the least amount of risk, okay? And they're going to weigh those options. Therapy is also tailored to the patient's needs, both by their other existing healthcare conditions, by finances sometimes, and then also, you know, whatever it is they're facing, how frequently they face it. Have they been treated for this before unsuccessfully? Things like that. Okay, so infection pharmacologic therapy include that the providers look for an anti-infective agent that is effective, has little toxicity or as little as possible, can be administered relatively conveniently, and is cost effective. All those things we just talked about. These are all things part of a program called antibiotic stewardship that helps us as much as possible prevent overuse of antibiotics and the inappropriate use of antibiotics. So pharmacy usually manages this, but these are some of the things that the providers look for when they're choosing a therapy. And then non-pharmacologic therapy, which brings in nursing intervention, so we can elevate the affected area. We can promote rest and encourage rest, provide adequate and appropriate hydration. The one thing we might do is to place sterile saline dressings over a wound to provide that barrier that the skin is not providing. So that would be one way. Sterile saline is not a it's not a medication per se, so it can be a nursing intervention. If you have doubts, just ask the provider, or if wound care is on board, you could ask them as well. Cold or warm compresses on the infected site. So that means, usually it's per the comfort of the patient, whatever feels better. Let me go back to sterile saline dressings on the wound. So, for example, burns are a specialty. That's not anything that, as a new nurse, you would encounter. However, because they have severe impaired skin integrity, we're talking about bad wounds or burns, like the entire body burns. Because they have severe skin integrity impairment, they have to be covered. So we have to provide dressings that, and depending on how severely they're burned, maybe from head to toe, to provide a layer of quote unquote skin via a dressing, because they don't have a way to protect themselves. So those are dressing changes in burn patients are hugely important, and to prevent infection, because we're trying to do what the skin is not able to do at this point in time. Okay, lifespan considerations in infection. So newborns, they have immature immune systems, right? They're protected by immunoglobulins received from mom in colostrum and breast milk, okay? Infants begin to synthesize the immune system at 1 to 3 months of age. So they're getting that stuff from mom in the interim, and then at about 1 to 3 months they start building, okay, their own immune system. And breastfed infants have been shown to have higher levels of immunity than non-breastfed infants. Infants, children, and adolescents. Infections are a normal part of childhood, okay? The majority of infections we see in this age group are caused by viruses. Infections in this age group, or these age groups, tend to be transient, benign, and overcome by the body's natural defenses and supportive care, okay? So that typically means that they don't, they're usually of short duration, don't have long-term implications for the patient, and left to their own devices, the body overcomes them on their own. So we need to, again, still, proper hydration, proper nutrition, proper supportive care of, maybe a Band-Aid over, that cut on the knee, but that cut on the knee doesn't require antibiotics. So that's what supportive care is. And even in these age groups, infants, children, adolescents, severe, even life-threatening infections may occur. And fortunately, that's at a low rate. Okay, infants, children, and adolescents continued. Fevers lower than 39 degrees centigrade or 102.2 degrees Fahrenheit in children should not be treated. So we talked about this earlier in the course. Fever is an indication that our body is working overtime, right? We have an increased metabolic activity to fight infection. That's what we're doing, okay? That's what the body's doing. So we just need to, again, provide provider guidance about how they want the fever treated. Children 6 months of age to 5 years are at higher risk for fever-induced seizures because they do have a lower seizure threshold. Immunocompromised children, such as those with chronic illnesses, need additional precautions. Good hand hygiene in child care centers and schools is needed to prevent infection spread, and that's just logical, right? But this can be difficult to teach these little people. So it's just repetition, 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 hand, water, and soap, friction. That's what we need to teach them. And then, of course, because of their impulsivity and lack of maturity, adolescents are at high risk for sexually transmitted infections. Okay, older adults. Normal aging may increase the risk of infection and delay healing. And that seems logical, right? We have a slowdown in our body processes. Our body systems aren't functioning as optimally as they once were. So for these folks, it's important to recognize and treat early. Okay, so again, assessment is key. We need to recognize things that seem like they could be a potential either risk or early onset of an infection. Special considerations for older adults are going to be things like perhaps they have poor nutrition, chronic conditions such as diabetes. We need to remember that their immune system reacts slowly, okay, to the onset of an insult. And then again, their normal inflammatory response is delayed. So they're not getting a leg up on this stuff. Okay, they're kind of already starting out behind the 8 ball. So prevention for these folks. UTI pathophysiology and etiology. So UTI is an exemplar for this concept. So let's talk a little bit about that. It is also one of the most common healthcare acquired infections. So pathophysiology review, the urinary tract is normally sterile above the urethra. So anything internal to the opening on the outside is sterile. It's kept sterile by the peristaltic activity of the ureter. So peristalsis helps urine flow out, so it should never be flowing backward or retrograde. And also by the intravesicular pressure of the bladder. So we're not going to get into intravesicular pressure. It's a method to measure bladder pressure. And they do this to do some studies for patients who are having problems with chronic UTIs. So UTIs can be bacterial, fungal, viral, community acquired, or healthcare acquired, and can be acute or chronic in nature. Urinary tract infections can occur in various locations along the urinary tract. Cystitis is the most common type of urinary tract infection, and pyelonephritis is the least common. Pyelonephritis is the inflammation of the renal pelvis and the parenchyma. So this is way up high in the urinary tract. So if the infection has reached that point, it's probably been present for a while. Very painful. Patients will be febrile, have pain over the flank pain. So this is serious, usually requires hospitalization and IV antibiotics, depending on the severity of the infection. All right, let's look at the causes. Etiology. Urinary tract infections are the second most common infection in children. And the reason for that is the pathogens enter from the perineal area. So sometimes when children are first learning toileting hygiene, that can be a challenge. Also, with females, it's important that they cleanse the area from the front of the body to the back, so anterior to posterior. And then 10 to 15 of hospitalized clients with catheters will present or develop a urinary tract infection. There is the vesicoureteral reflux, and I just mentioned in a previous slide that urine flow should never go back toward the kidneys. It should always come toward the externally towards the body, outside of the body. So this can also cause urinary tract infection. That's a condition that requires different types of treatments. Renal scarring from chronic urinary tract infections or other types of renal disease can cause scarring that can put a patient at greater risk for urinary tract infection. And the urinary tract infections of either frequent or chronic nature can increase the patient's risk of kidney damage. Okay, let's talk about some risk factors that place individuals at a greater risk for urinary tract infection. So adult females, the risk increases with sexual activity, increases with the use of spermicidal compounds, increases with the use of a diaphragm for contraception because of the pressure placed on the urethra. If there's sometimes just in a particular individual, they have a lack of a normally protective mucosal enzyme that protects the mucosa in the urinary tract from bacterial invasion. And so if you're just lacking that, there could be a number of different causes that can place an individual at higher risk. Personal hygiene, as I talked about, is important for not just children, but individuals of all ages, both hand washing before and after use of the bathroom, before and after sexual activity, and the appropriate hygiene from anterior of the body to posterior of the body. And then voluntary urinary retention. So we kind of laugh and say that nursing school places nursing students at higher risk for urinary tract infections because we're sitting in class for a long time, because we're in the clinical setting and we don't take the time to use the bathroom when we feel the need. Nurses also do this. You will hear nurses joke, and it's usually not a joke, have gone to the bathroom maybe only one time in a 12-hour shift. So empty your bladder whenever you feel the need. Don't wait, don't put it off. And also encourage patients to do the same. As soon as they feel the urge to go, then they should be going to the bathroom or asking for assistance to the bathroom. Okay, additional risk factors. Pregnancy. Risk of urinary tract infection increases during pregnancy, particularly in the second trimester due to the enlarging uterus, and then the pressure that can be placed on the urethra during, and the ureters also during pregnancy as baby grows. Pregnant women may have asymptomatic bacteriuria. So they may have bacteria in their urine and not realize that they may not be having symptoms, but it's found as a subsequent finding. Urinary stasis and incomplete bladder emptying. So because of, there could be a number of different reasons for incomplete bladder emptying, but sometimes it's just the anatomical location of baby, and could be potentially blocking the ureters and the urethra, things like that. So pregnancy just brings a whole other another component of risk for a lot of different conditions. Urinary tract infection is a significant risk for mother and the fetus. So now we have an infection, right, that's very close to the vagina for transfer of bacteria. So we need to make sure that moms are being hydrated, that they're not retaining urine voluntarily. They need to go when they feel like it. Postpartum women are at increased risk for UTI. Sometimes it's pain, depending on the type of delivery they've had, as far as episiotomy or tears or things like that. And also newborns may have a UTI from exposure to feces in the diaper. So obviously, children who are still of diaper age, they have that there, and maybe, mom or caregiver doesn't realize it right away. And so there is a prolonged exposure to feces in the diaper. So we need to make sure that we're checking them frequently, as well as same thing, little girl babies, wipe from front to back. There are fewer situations that place males at risk for urinary tract infection. Prostatic hypertrophy, so this is a enlarged prostate, essentially, okay? And so what happens is it encloses, it constricts the urethra, where the urine passes from the ureters, and then they converge into the urethra. But males have, if the prostate is enlarged, males may have a difficulty starting the stream, or also completely emptying their bladder because of the prostate. Bacterial prostatitis is a bacteria that causes inflammation in the prostate. So maybe this isn't a chronic issue as in the prostatic hypertrophy, but bacterial, there's a bacterial infection that causes the same type of symptoms as the prostatic hypertrophy, but it can be treated with antibiotics if it's bacterial. Circumcision is thought to be protective of the male genitalia, but also it needs to be appropriately cleansed. Hygiene is important even for males, especially in uncircumcised males. And then anal intercourse also places males at increased risk for the transfer of bacteria from the rectum and the anus to the urethra. Okay, increasing age places both men and women at increased risk for development of urinary tract infection. Especially men, older men, are at a higher risk than women. An enlarged prostate, as we mentioned previously, associated with cystitis, causes older men problem. Increased risk of urinary stasis, so they're not emptying the bladder when they feel the need, or they have urinary retention after emptying the bladder. Chronic disease states can put the older male at risk for urinary tract infection, as well as an impaired immune response. And then older women, there's two things that place older women at risk for urinary tract infection. These do occur in younger women, but less frequently. A cystocele, which is a prolapsed bladder, so the bladder has fallen, come towards the distal portion of the pelvis, and it should be kind of more suspended upward towards the abdomen. And then a rectocele is where the wall between the vagina and the rectum becomes weakened, and those are conditions associated most often with age. We're not going to get into those, but those are two reasons why women may experience a greater risk in older age of urinary tract infection. All right, UTI prevention. So let's talk about this in terms of patient education, okay? So we need to encourage a practice of good personal hygiene, which means that they are maintaining generous fluid intake, right? So the more fluid that your body processes, then the bladder can remain flushed, okay, by way of the kidneys making urine and flush to the outside of the body. Emptying the bladder every 3 to 4 hours. Again, women needs to cleanse from front to back. Void and wash the perineal area before and after sexual intercourse. Maintain the integrity of perineal tissue. So this is just like any other skin tissue, but it is a way, again, just like impaired tissue, skin tissue anywhere, would allow a portal of entry for bacteria, right? And then maintain the acid in the urine, which acidic urine doesn't allow bacteria to grow because the acid kills it. So there have been some information around like cranberry and increasing the acidity of the urine, like exogenously, but and those would all be things that they would you could talk to the provider about and ask him about what his personal preference is for that, if that is part of his practice. Okay, so we want to identify and treat urinary tract infection as soon as possible. So let's talk about what we're going to be looking for. So the clinical manifestations of UTI depend on the location of the infection, so where it is in the urinary tract, and the age of the patient. So the infant may have non-specific symptoms. They're not going to be able to tell you if something hurts. They may have crying upon urination. You may or may not realize that they are having frequent urination, but in small amounts. So that can be a little bit difficult. A patient younger than 2 years old who has a fever of unknown origin, which is FUO, need to be tested for a UTI. Now, this is not the nurse's job. This is just in a standard of care, one thing that we would look at for kids younger than 2 years old with a fever. Typically, the presenting symptoms of a urinary tract infection are dysuria and nocturia. So difficulty urinating is dysuria, and nocturia, they're frequently urinating at night. Frequency, urgency, foul odor of the urine, pyuria, which is pus in the urine, or hematuria, which is blood in the urine. So I know it sounds strange. Foul odor can definitely be an indicator, or one of the things that would go along with the symptoms, which seems kind of strange. I don't really want to smell urine, but you may notice it just in like emptying a Foley catheter or emptying a hat in the toilet. And so that's something that you would document. Urinary tract infection lifespan and cultural considerations. Older adults often present with non-specific manifestations. So they're up in the night, going to the bathroom. Incontinence, so they're soiling themselves when they previously had not been. Confusion and behavior change. This is one of the most frequently seen symptoms in older individuals. I've read research and studies supporting both ways, meaning yes, it is a symptom of urinary tract infection in older individuals, and no, it has nothing to do with urinary tract infection in older individuals. I will say though, from previous experience, we'll have, older individuals come to the facility, both men and women, whose family says, they're confused, this isn't like them, they don't normally behave this way. Oh, lo and behold, they have a urinary tract infection, and then we clear it up, and within a couple of days, yep, here they are, just like they were before, the hospitalization. So that is my personal experience, but I personally have found that to be the case. Lethargy, just don't feel well, and that's another thing, confusion, behavior change, and lethargy. Loss of appetite, again, just not feeling right, I just don't feel well. And then fever or hypothermic. So just because the patient doesn't have a fever does not mean that they do not have an infection. Okay, cystitis is the most common type of urinary tract infection. It is usually uncomplicated and readily responds to treatment. Catheter-associated urinary tract infections are often asymptomatic, and these should be a never event. So we should be performing regular and effective catheter care and perineal care. We should be taking the indwelling Foley catheters out as soon as possible. So those types of things will help prevent development of urinary tract infection. Most catheter-associated urinary tract infections resolve quickly when the catheter is removed with a short course of antibiotics. And then this has become used heavily in practice. We need to weigh the benefits and risks before using an indwelling catheter. So in patients, I would say 90% of patients in the hospital would have a Foley catheter. Now I would say less than 10% of patients in the hospital have an indwelling catheter, because we found that they were not being maintained appropriately. They were not being inserted using sterile technique. So a lot of things put the patient at risk just because they had an indwelling urinary catheter. So there are other ways to measure output, and you'll see those in use in the clinical setting. I know Kafir Valley and Highsmith their indwelling catheter use is way down. So some diagnostic tests that we're going to use to determine the presence of a urinary tract infection would be a urinalysis. So the lab, we do not do this on the unit because of quality control requirements. A nitrite dipstick, so you would dip a stick into the urine. But again, we do not do that at the bedside. Another urinalysis would include one of the elements of the urinalysis is a leukocyte or leukoesterase. Presence of leukocyte esterase is indicative of urinary tract infection. So we do not diagnose them as nurses, but if you quickly glance at a urinalysis and see leukoesterase positive, then you can pretty much be assured that the patient has a urinary tract infection, and then anticipate something coming for treatment of that from the physician. In order to get a urinalysis, you need to use a clean catch specimen. And that has specific instructions. You need to instruct the patient how to appropriately collect the specimen without contaminating it. And then sometimes it is necessary to use a straight cath. So we would insert a catheter into the bladder, collect a specimen, then withdraw the catheter. We would not leave it there. Sometimes that is necessary. Gram stain we can use to determine what actual microorganisms are growing by looking at the urine under a microscope. Culture and urine culture and sensitivity, the same thing. So we can determine what's growing and then determine the appropriate antibiotic for that particular microorganism. And then a white count, WBCs with differential. So a white count, we're going to take a look and just decide if patient has a elevated white blood cell count. Okay, for individuals who experience recurrent infections, that usually requires additional testing. Of course, that's up to the provider to decide why they're having recurrent infections, okay? So there's an intravenous pyelogram, which is an IVP, avoiding cystourethropy. So that's, they use a camera to look into the bladder in the urethra as the urine is exiting the body. Cystoscopy, the same thing. They're going to take a camera and they're going to insert it into the urethra to look into the bladder. A manual pelvic or prostate examination, it could be, related to some type of mass or tumor, or again, enlarged prostate can be found on manual examination. A renal and a bladder ultrasound to see if there's anything unusual about the anatomy of the kidneys and the bladder, and then a DMSA scintigraphy. Again, this is not something that I have any experience with or seen used. I'm going to be used in a specialty area such as urology. Probably that's about the only place. Again, these are just so you know, there are things out there that we're going to use past blood work to determine the cause of a urinary tract infection. And sometimes, just to make you aware, there are sometimes surgical interventions required depending on the diagnostic testing results. So sometimes calculi, which are kidney stones, require a surgery or an intervention. Structural anomalies, so congenital defect of some type, or a mass or something of that nature. And then strictures. Sometimes the urethra or the ureters become narrowed to the point where it impedes or occludes urine flow. So those would be reasons for surgery. Ureteroplasty is a surgical repair of the ureter due to structural abnormality or a stricture of the ureter. So again, just know that they're out there. Okay, what are we going to do? What can we expect for these patients? For an uncomplicated lower urinary tract infection would be a short course of antibiotic therapy. The antibiotic will be selected by the provider based on the age of the client, the sensitivity, or what kind of microorganism is growing and what it's sensitive to, what antibiotic will kill it, the patient's renal function, and then the client's signs and symptoms. There could be, depending on additional medications prescribed to ease pain, and could also be how quickly IV or PO, which medication is selected and prescribed. Follow-up culture in 48 to 72 hours should be used in a pediatric patient. TMP SMX is sulfamethoxazole and trimethoprim, another, like I said, choice of antibiotic that the provider may choose based on the things that we talked about in the previous slide. ASB in catheterized clients. So patients who have catheters sometimes may, in a urinalysis, may known to have asymptomatic bacteriuria. So that means that they have bacteria in their urine but are asymptomatic, and sometimes that's due to the fact that they have a catheter, so they wouldn't be feeling those symptoms of pain on urination or frequent urination, especially frequency and small amounts. So and this is just another category of patients who they may choose pharmacological treatment for. Okay, so as nurses, some of the interventions we can use are to instruct patients to drink adequate amount of fluids, especially water. Cranberry juice, as I mentioned earlier, may be some patients beneficial, and some providers may recommend it, others may not. And then to avoid fluids that irritate the bladder, such as caffeinated beverages, alcohol, and citrus juices. Okay, so the nursing process, we talked about assessment. Let's talk about what we're going to do going further. So intervention and implementation focuses on returning the client to maximum health, right? So we're going to encourage fluids, we're going to encourage voiding when they feel the need, proper hygiene, health promotion. So individuals who are have good nutritional status and who are well hydrated are less likely in general to develop illness or disease. And then again, teach measures to prevent urinary tract infection, especially to young sexually active women. In patients who have a urinary tract infection or suspected of having one, we need to take an appropriate health history, which includes the symptoms, a history of urinary tract infections in the past and pregnancy, and then the use or absence of birth control, and then chronic diseases that the patient may have. On physical examination, we would look at their general health and take their vital signs, look at the abdomen, the shape, its contour, and the tenderness. Sometimes individuals with a urinary tract infection will have tenderness over the bladder to palpation. And also, I mentioned to you that pyelonephritis often those individuals develop costovertebral tenderness. So if you've had a provider kind of like pound on your back over where your kidneys would be, that's the reason why. Tenderness there is not normal. So that would be something out of the ordinary or an abnormal assessment finding. Again, implementation and intervention, we're going to manage pain according to the orders written by the physician, the physician's assistant, or the nurse practitioner. Pain is common in both lower and upper urinary tract infections. We need to assess pain, including quality, intensity, location, duration, and timing means when does it come on? Does it come on while you're urinating, before you're urinating? Is it there all the time? Aggravating and alleviating factors. Is there anything that makes it better or worse? We need to teach the patient if they're able to help themselves in this way, or provide comfort measures. So sometimes it's maybe a warm pack to their back. Positioning could be one. Increase fluid intake unless it's contraindicated. And then instruct the client when to notify the provider. This is especially true for patients who would be leaving the facility. So that usually includes, symptoms that are the same or worse than what brought you to the hospital, or fever greater than 100.5, whatever the parameter is. So it's things like that. We need to make sure that the patient's getting better and not worse. Community-based care, so that's going to be, outside of the hospital. So we need to provide, again, patient education and instruction. What are the risk factors for urinary tract infection and how to minimize the risk factors or eliminate them? What are the symptoms of early urinary tract infection and the importance of seeking medical intervention promptly? Maintaining an optimal immune system, which again addresses nutrition and hydration and hygiene. Complete the prescribed treatment. If the patient is prescribed antibiotics, they should be strongly encouraged to finish the entire course as they're prescribed and not decide that because they're feeling better, they can stop taking them. And then as nursing personnel, we need to minimize the risk of urinary tract infection when an indwelling catheter is necessary. And so again, that's going to be proper maintenance and hygiene, removal as soon as it's medically indicated, making sure there are specific components that go along with the patient having a catheter. So the catheter, the drainage bag has to be below the level of the bladder. The tubing, should be like hanging off the edge of the bed. It shouldn't be level with the bladder, meaning the urine wouldn't necessarily drain by gravity. It could stay in the bladder, which is one of the things that we don't want. Interventions for nurses, we need to facilitate effective urinary elimination. So we need to provide easy access to a bedpan. There are patients who can place themselves on a bedpan, but if that's not the case, we need to make sure that they have their call bell within reach so they can let us know when they do need to use the bedpan. We need to monitor the color, clarity, and the odor of the urine. We need to instruct on the liquids to avoid. So in the hospital, probably that would not be alcohol, but it would be caffeine and citrus juices. And then if they are alcohol users, at home, that would be something that they do need to avoid. We need to use strict aseptic technique when catheterizing a patient. This is a sterile technique. This is the only acceptable technique for inserting an indwelling urinary catheter or for straight catheterization. And use intermittent straight catheterization whenever possible, as opposed to placing an indwelling catheter and leaving it. Again, part of our nursing responsibilities are to maintain a closed drainage system. So that means that we're not going to disconnect the catheter from the drainage bag or any part of that. So if that would need to happen for whatever reason, then the whole catheter needs to be removed and a new one inserted using sterile technique. We don't disconnect them to like put a new drainage bag on or anything like that. We maintain the system as closed. Use aseptic technique when emptying a catheter drainage bag. So we don't lay the drainage bag on the floor. We don't lay the, drainage spout on the floor. We need to make sure that we're using gloves when we're touching the drainage bag. And then we provide perineal care on a regular basis, which is at least once a shift, and more frequently when necessary, and especially after defecation. So the area needs to be cleansed and it needs to be dried to decrease the moisture, because the catheter could be an irritant just because it touches the skin. Okay, if we do need to obtain a specimen, we need to instruct the patient on how to properly obtain the specimen without contaminating it. We need to assess the patient's knowledge about the disease. So do they have specific conditions that put them at greater risk for developing UTI? So could be things like development of kidney stones. Have they had chronic urinary tract infections? Have they had surgery on the urinary tract infection that could place them at greater risk? Discuss the prescribed treatment plan, and this includes, as I mentioned, making sure that they understand that they need to take all of the antibiotics as they were prescribed for the full course. If patients need to develop a plan for taking medications, sometimes that's necessary. We need to make sure that the patient understands how to take the medications, when to take them. It's possible that maybe the patient gets home from the pharmacy with medications, a big tablet that needs to be cut in half. We need to make sure that, if they have questions about it, that they're contacting somebody, their doctor's office, or sometimes there's a care line that they can use to ask questions to be sure that they're compliant with their medications. Strongly encourage them to keep follow-up appointments. That's important to be sure that they are well and that they know what they need to do to stay well. And then also, again, teach measures to prevent future urinary tract infections.